As Allison shared with you guys, I'm an occupational therapist, and in the world of occupational therapy, we love to look at what people do with their time, what occupies their time, and then we consider how life, injury, illness can impact engagement in your favorite occupations. So we think about driving as one of the most valued occupations we can participate in. So I wanted to start out with a little bit of how I think about driving, because I think that'll give us a lens for our conversation today. So here's my information, and I will put this up again at the end of the presentation. But I do own my own private practice, Adaptive Mobility Services. We're here in Pennsylvania and New Jersey. And just as a note, since we're talking about driving and there can be a lot of different questions related to that, I wanted to reinforce that the information shared today is for educational purposes. And of course, we would need to have an individual discussion if we were talking specifically for you. Okay, now let's just start with kind of my lens when I think about driving. There is a researcher, a scientist, his name is Mishan. He developed this driving behavior model, and this might look a little overwhelming at first, but hopefully it kind of brings this all together. When we think about the task of driving, as a specialist, we always break it down into kind of three categories of operational, tactical, and strategic. Driving requires people to first learn how to operate the car, then bring those tasks together to do a tactical operation, and then involve strategic thinking. Okay, so let's talk about some examples with this. So the task of driving operationally would require somebody to understand how to turn on an engine, how to press a brake pedal, how to read a speedometer, and how to, apply the turn signal. So we're thinking about operational tasks require vision for seeing, motor movement for usually for doing, and thinking components for doing the task. The tactical piece is kind of the next level when driving behaviors. And if you think about a new driver, right, learning to drive, we first teach them things like operationally how to turn on the car, how to turn the wheel, how to brake, push the brake pedal. The next phase is the tactical. Tactical gets into the idea of how do we put those pieces together operationally to do something, like how do I press the brake pedal just so I stop the car at a stop line? How do I press the accelerator and turn the steering wheel so that I can stay in my lane when I'm making a turn? How do I look at the traffic and know that there's going to be a break and there's enough space or gap for me to start my left turn and to turn across the lane? Those are all tactical skills. The highest level of driving behaviors is strategic, and that has to do with knowing how to navigate and get around. And again, if you think about new drivers, we first teach them how to turn on the engine, use the gas and brake. Then we teach them how to go around the neighborhood, go to places that they know how to go to, work at stop signs. Strategic then gets to the navigational ideas and the higher level activities, like knowing how to manage a detour when that comes up. Yesterday, I was down in outside the Philadelphia area, and I feel like every road had construction. And almost, as I hit the construction zone, one lane would be closed and you had to figure out which lane you had to go in and follow the cones. There were also several streets in one neighborhood out kind of in the Ben Salem area where several of the streets were completely closed for construction, and we had to figure out how to detour around that. Those higher level driving behaviors are known as strategic. I bring all this up because when we talk about driving, often people will say to me, Susie, I've driven for 30, 40, 50 years and I've had a perfect driving record. And that may be true. And that's actually a wonderful thing, right? But what can happen when we're talking about changes in cognition, a condition that might be changing thinking or problem solving, a condition that might be changing attention or how quickly you think on your feet, we start to see changes in behaviors between the strategic activities. And that's where we can kind of start to see warning signs or conditions we have to think about with driving. Then there are times that the condition will even start to go back even further, impacting tactical skills. And then the worst impact would be if it's starting to impact operational skills. So I want you to kind of keep this lens in mind as we're talking today, because my role as an occupational therapist specializing in driving is to look at the different things that we do in our life, the different ways we operate our body, and how it's impacting these operational, tactical, or strategic driving behaviors to know if somebody still has fitness to drive, if it's starting to change, or if we need to start having conversations about driving retirement. Okay, so hopefully that makes sense. I'm going to pause there in case there's any questions with kind of Mishan's driving behaviors first.
Not on Mishan's driving behaviors.
Okay, great. Thank you. So I'm going to switch gears here, and I want to bring you now over to my website. So let me tell you, now that we kind of have this frame of reference, what I do as an occupational therapist who specializes in driving. There are several of us out there. I will say that across the country, they only estimate there's about 500 specialists. So while I say there's several, there's still more of us. But we're a unique breed. And so what we do is we work with people who are driving or who want to become drivers, who are experiencing a change because of an injury or illness. And we look at if someone has the fitness to continue to drive. So as Allison mentioned, if you visit my website, I work with both drivers and with occupational therapists. So if you came to my site, you'd want to come over here to the I'm a driver, I'm concerned about a driver. And this will bring you into some information about what I do. I just switched pages so that I wouldn't have to scroll so much on you guys. But let's talk about what it looks like when I work with someone. So when the doctor says maybe it's time for a driving evaluation, or if as a family member you're concerned, or even if as a driver you start to have concerns about if you're having an impact, what we do is called a comprehensive driving evaluation. The evaluation is set up, my company's set up, where we will actually come out to see you in your home. So you get the home court advantage, which I think is a really nice way to do things, especially if we're talking about driving. It's nice to be in a familiar environment. It's nice to kind of know where you are when you're starting out, right? So the evaluation, I typically schedule about a 3-hour appointment. And that 3-hour appointment has 3 different parts. The first part is clinical testing. So for the clinical testing, it says clinic, but this happens usually in a kitchen. We'll sit down at a kitchen table. I like to sit down with the driver and at least one other family member to gain an understanding of this person and kind of their medical history. Then after I kind of understand the person, their medical history, their driving habits, I'm going to dive into the different things that we use to drive a car. So as I mentioned with the slide about Mishan, we use our eyes, we use our brain, we use our body movement to do different things in the car. So I want to test those pieces individually if I can before we get in the car. So our clinical testing, we would sit down and I'm going to take a look at vision. And I specifically measure, visual acuity and visual fields. Next, I like to look at how somebody's doing moving. And for driving a car, I look at how they move their arms and their legs. I check sensation in the feet. And then I also like to check brake reaction time. So I have a piece of equipment that I bring into the home, we set up, and I look to see how fast can the driver go from the gas to the brake. After I have a good understanding of how someone's seeing, how somebody's moving, then I dive in with a couple activities to understand thinking. And with that, there's many different pieces to thinking, right? So it's not just looking at memory, but I'm doing different tests that look at memory and attention and problem solving. I use all of that information to help inform me. And then what I say to the driver is, okay, now let's talk about where you typically drive. And I want you to pick 2 or 3 places that you normally go to. Let's set a plan. And now you're going to take me to those places. So we'll go out to the car. We do use my driving rehab car for this next part. And I know that can be an obstacle or a little hurdle for a lot of people because we all like to drive our own vehicles. But I promise my car has a steering wheel and pedals just like yours. So the first thing I'll do is let people get used to my car. Again, we're in their neighborhood usually, so they can drive around their neighborhood, make sure the mirrors are adjusted the way they'd like them to be, make sure the seat is comfortable, feel out the brake. Then after they get used to my car, I have them follow the plan that they set, going to 2 or 3 different places that they normally go to. I like that to include, a sample of the different activities of driving that they normally do. So if somebody says, Susie, I never get on the highway, well, we're not going to do the highway. But if I have somebody who says, I do the highway and I like to do the turnpike, we're going to head out there and check it out to make sure that that looks okay. Along the way, if someone's doing really well, to get at that highest level of driving, that strategic thinking or navigation, I'm watching for things to make sure that the driver can think on their feet. So I'm watching to see, do we have a delivery truck stop in front of us and the driver has to problem solve that? Do we go into a construction zone and we have to problem solve that? And if we somehow end up doing a drive where there really aren't any problems along the way, I'll create or add my own problem and ask the driver to think on their feet by finding, the next gas station or rerouting us, leaving a different exit from the grocery store or so on and so forth. So I can really make sure that someone's doing well with their driving. After that second part, what I do is I use the first part where I'm looking at, the vision, movement, and thinking. I take what I saw in the car for the second part, and I start thinking about the patterns that I'm seeing there. And is someone showing me a pattern where everything's looking well and they're having, safe driving behaviors? Or are we starting to see a pattern of change that we maybe have to think about and be concerned with? We use that information for our outcome discussion. And then that outcome is shared both with you and the referring neurologist so that we can talk together about what the next steps are. Are there any questions kind of with the comprehensive driving evaluation piece, those 3 different parts and how that works together?
Susie, you might answer this later, but I'll give it to you now. This person is saying, we've been concerned that in our country's litigious environment, no place that provides driving evaluation for people with cognitive and/or memory impairment would be willing to, or at least very reluctant to, certify an individual, as a competent driver. It seems that they would be afraid of being held legally liable if any individual that they were certified was involved in any kind of accident. Do any of them certify memory or cognitively impaired individuals as okay to drive?
Okay, so that's a really great question, and you are so right. We live in a country where we have to think about that. So when I see someone, I can use all the information from the part 1 testing and the on-road to say what pattern I'm seeing. And in that moment, if somebody has fitness to drive. But I can't predict the future. And in fact, PennDOT and the New Jersey Motor Vehicle Commission will say, you can't predict the future. And so you're not going to run into any specialists that say you've passed or you're okay to drive, because we can't predict what's going to happen in the future. But I can say in this moment of time, I'm seeing a pattern of safety. You're showing me fitness to drive. And in conjunction with the neurologist, we don't have a level of concern where we feel like something needs to change yet. So our wording is a little, most people, they ask me, they say, did I pass? And I have to come back and say, okay, on this date, what you've shown me in this moment is safety, right? Because I can't guarantee what you do tomorrow or the next moment is going to be safe as well. So you won't see anybody actually certified individuals or certified drivers in that respect. Does that make sense?
We'll wait for the reply, but I think that's very helpful answer.
The other thing, kind of while we wait for the reply, is it's really interesting to think about, but I had a really unique conversation with actually, this is when I was working in Maryland. And what Maryland Motor Vehicle had said to me is, they said, Susie, you actually aren't the person who's issuing the driver's license. So you're not the person giving permission. It's the state that's giving someone permission. What our role in the process is to say if we have a level of concern that could impact safety, right? And so that's where we become partners at times with PennDOT or New Jersey or Maryland Department of Motor Vehicle Association. And the way the state laws are written are different for licensing in each state. And this was going to come up a little later, but it seems natural to talk about it now. One of the questions I often get is, will my information be reported to my driver's license administration? And that is state specific. My job is always to share with the driver and their family what's going on, as well as to report back to the physician. And then collaboratively, if the physician feels like there's a safety concern, that's when we're obligated to take action. Most states, it's a minimum of, if we have a concern with safety, that's when we need to report. But even there, that reporting will trigger review. It doesn't necessarily trigger the revocation of the suspension of a license.
Okay, so we got a response. Yes, it makes perfect sense. Thank you. And then we have two more questions more about the evaluation. So question one is, does the family member who's present go on a test drive with you?
Oh, that's such a great question. In my company, my policy is no. And that's for two different reasons. First, my liability insurance, they're not big fans of having extra people in the vehicle. But second, from my experience, I've already, while I've been building rapport with the driver kind of during the first part, it's still very nerve-wracking for them because we're talking about driving. And so I want them to be as comfortable as possible and as relaxed as possible. And what I found is that having extra people, even if they're quiet in the back seat, can just add to some anxiety. And so I feel most comfortable setting up a situation where it's just myself and the driver. Now, I've had situations where after they're comfortable and I'm comfortable, for one reason or another, I've invited a family member to join us in the vehicle. At that point, though, I have them sign a passenger liability release, and then we might invite them in the car. But for the most part, it's not something that happens on the evaluation.
Thank you. And then a different question, who typically does the referral, or who typically refers to you? Is it neurologists, other types of doctors? Who do you get your referrals from?
So that can really range and vary. A lot of times, I would say that in my practice, a handful of referrals are actually coming from family members. They've sought me out for one reason or another. And they want to know if their loved one is okay, or if they're maintaining their skills. And so some referrals come directly from families or even from drivers. And then a large part also come from physicians, and the physicians can be the general practitioner or neurologists. I get quite a few referrals from orthopedists as well. Being an occupational therapist, no matter kind of where the referral comes from, I do always get a physician order. In Pennsylvania and New Jersey, where I practice, I need to have a physician always ordering and overseeing what I do. So I do always loop in the doctor, but it can really vary. I would say, you guys are all hooked up here with the Penn Memory Group. And so your referrals typically would come through the neurologist.
Okay, thank you. Let's do one more question now, and then we'll move forward. Does insurance cover this service?
This is a great question. I'm glad that somebody asked this. So typically, insurance does not cover what I do as a driver rehabilitation specialist. I see typically because there are some situations where if you start with an occupational therapist at an inpatient setting, and they might cover some of the clinical testing, but then you'd still have to be referred to me for the on-road portion to get the whole picture of somebody. What I do, unfortunately, it's the hardest part of my job, but Medicare has determined that driving is not an essential activity, and so it's not covered with their program. And most other insurances follow what Medicare does. So adaptive mobility is a cash-based service, and it is out of pocket. But with that in mind, we really try and make it valuable for the driver and their family. Excuse me. It's interesting because even as an occupational therapist practicing in this area, my general OT liability insurance doesn't cover me. I have to even get special liability coverage. And I think a piece of it is because this area of driving is a higher risk. And it's just still an area of interest that keeps growing. So it's not covered yet. And I'm not really covered either. I have to get my own coverage so that I'm set.
Wow. Okay. Thank you, Susie.
Yeah.
Someone is asking if Penn subsidizes any of it, and the answer is no. Susie, I'm going to have you maybe go on, and then we'll do another pause for questions whenever you're ready.
Yeah, absolutely. I'll just say one more thing about funding is, so typically if we're talking about a driving evaluation related to some kind of change in cognition, so that's going to be the one-time evaluation fee and then a reassessment if recommended. We'll talk about reassessment here in a bit. But and then the other thing is, there are some funding sources, but most of them will only fund for driving evaluation if this is being requested so someone can continue to work, or because they have potential for a vehicle modification. So for example, if someone's had a stroke and they can't use one arm or one leg, there can be funding resources to cover that. But typically, if we're talking about a condition that may get worse, most of those funding and grant resources won't cover the driving eval. So kind of moving on, I want to switch screens here back over to my PowerPoint, and I'm going to skip ahead a slide or two. Let's see if I do this correctly. Let's talk about timing a little bit about when you would have a driving evaluation, because this is something that I've actually I've changed my opinion on over the years. And a lot of that is because we didn't used to have a lot of great research with relation to driving evaluations and especially cognitive conditions. And now we have more research around that. So I'm going to give you some information, and a lot of that is from this resource, the National Guidelines on Driving Dementia, which was published in 2018. So initially when I started in driving rehab, which was over 20 years ago, we used to see everybody, and we used to see them, we'd wait and we would see them when they were kind of in like a moderate dementia phase or later, which we're learning is that's really not the most helpful time period. If we go to the guidelines on driving dementia, there's a couple important things that they've stated. And I think these are helpful to review. So the first thing they stated is that the diagnosis of dementia alone is not sufficient for withdrawing driving privileges. And I think that's really important because we're getting better as a group, as a medical group, of diagnosing people earlier in their condition. And so we might have individuals who now we're seeing more diagnosis of mild cognitive impairment, or at least I'm experiencing that. More diagnosis of mild cognitive impairment. And we know that that doesn't always progress to a dementia, right? And so having a cognitive condition or a diagnosis of dementia does not mean we have to immediately withdraw driving privileges, which it used to, that's what it used to mean. But we do know the research is very strong in this, that individuals in the moderate phase of dementia are unlikely to be safe drivers. So when I talk about timing, I used to have people, the doctors and families, and I mean, all of us, we used to delay the driving evaluation until somebody was really kind of progressed in their condition. And the tough part about that was, we were delaying it, we were delaying the conversation, and then we were all of a sudden saying it's time to stop rather than helping somebody prepare along the way. What I've started to experience with the Penn Memory Group and some other neurologists in the area is the referrals for driving are coming earlier in the condition. And this is extremely helpful, not only for understanding the driver, but for helping the driver and family prepare for the future. Okay, so let me just kind of break this apart. So while the diagnosis of dementia is not sufficient for saying you have to stop, we do know people with a moderate phase are likely to be unsafe. And we do know eventually with dementia, you do have to stop driving. So driving retirement is on the table. With that aside, driving retirement's on the table for all of us. The research has shown that women will outlive their driving ability by 7 to 8 years and men by 6 to 7 years. This is interesting because we all really need to think about driving retirement, even though it hasn't been much of a conversation yet. Okay, so I just as a little footnote, I think that's interesting. Okay, what happens when we start the driving evaluation earlier in the disease process is we're able to really help establish baseline for the person. So a wonderful example, I worked with a family this week. She was diagnosed in April, it was April or May, with her cognitive condition. And I saw her now just about 6 months later. And it's really helpful because while she has some initial symptoms, I was able to gather kind of baseline information on her. We were able to go for a drive. There was a strong pattern of things going very well and beautifully. I now have that baseline information. So when the doctor says, Susie, I'd like you to revisit this maybe next year, I have something to compare them to. It's also really helpful to see somebody early in the condition because not all of us are perfect drivers, right? So some of us have unfavorable driving behaviors, not consistently using a turn signal, sometimes going over the speed limit. Some people are not great at stop signs in their neighborhood. I see this a lot where people kind of have rolling stops. When I see somebody early on, I can start to differentiate, is that a bad driving behavior or is that a symptom of their condition, right? Because being kind of not great with your turn signals can be a bad habit, but it also can be one of the things that I see drop out when tasks get harder and somebody's having difficulty doing more than one thing at a time. But if I see them earlier in their condition, it helps me to understand that better. I think that it's really become interesting. The other piece is I like to see people earlier in their condition because then I can say, kind of working with the medical group, what's their kind of trajectory here? And we can start talking about, okay, what happens in 6 months? What happens in 12 months? Should we start tracking, should we share our location? I'm just looking for my cell phone. I put it in the other room so I wouldn't be distracted. I was going to hold it up. I share my location with my family so they know where I am, right? And I always carry a smartphone with me. But if somebody, if I evaluate somebody and they're doing well, I'll talk to families about sharing the location on your smartphones so that you know where each other are. So you can start to understand if somebody's driving habits are changing a little bit. We'll talk about warning signs, things like, if they start to, maybe if they get lost or turn around, that's of concern. And we can use all of that information together to help understand when and if that transition then from the driver's seat to the passenger seat needs to happen. So I really love this with seeing people earlier. I think that it's, for many people, it's a great way to kind of look at them and say, okay, yes, you're going through this condition, or yes, here we are in this part. But we're seeing a pattern of safety with the driving piece. So you can continue for now. Let's continue to revisit this. And then we actually are able to see if the changes are happening and help to make those decisions to keep the person as safe as possible. Because our goal is always autonomy, but safety, right? So as much independence as possible with safety as well. So I love coming into the situation earlier so that we can really understand what someone's doing. And the last bullet here is when we start the conversation earlier, we all have time to plan then for that driving retirement. So I've worked with some people where I see them for their first evaluation. And then the doctor, is checking in, the neurologist is checking in every 6 months. And so maybe it's been 12 months and the neurologist says it's time to go back for a reeval. And I'll have some family members say, we got another year out of driving, but we're ready to hang up the keys. That is the best possible outcome there could be, is for the driver or the family to make that transition themselves, or to know that that transition needs to happen. That's a wonderful outcome. And I think from having the conversation earlier and starting the process earlier, it helps us all arrive at that decision more easily. So I'm a big fan of doing this earlier on. The other piece, and let me see where I am in my slides. Oh, I'm going to go to the next slide here really quick. The other piece is part of what I do that's unique as an occupational therapist is what I told you, I do different activities to look at thinking. And my activities are not always paper and pencil. Sometimes my activities are observing the driver doing things in the home, making an omelet, making a peanut butter and jelly sandwich, watching them do different, what we call instrumental activities of daily living. Because understanding how someone does at some of those activities can help us understand what's going on in the car. The research from that group, the national guidelines, has highlighted that people with a progressive loss of 2 or more activities of daily living are at higher risk for driving impairment. So my background as an occupational therapist who looks at these activities of daily living can really help to then build this robust picture. So the initial scenario I was talking about with the woman I saw this week, she's still paying her bills, managing her calendar, doing all the cooking for the home, doing all the grocery shopping. Her IADLs are fully intact. And so I'm using that as part of the picture I'm painting and part of the information I'm sharing back to the care team. I'm also pulling in a couple different tests and measures that I think help to fill out the picture as well, that can give a different view from just being in the office, which is another reason why I think it's helpful at times. At least maybe I'm over interpreting this, Allison, but I think helpful for you guys as a team, because then I can say, I've seen this person in the home. I've seen how they're doing. I've seen how, I've even had people stop during the evaluation to pick up a prescription or to go in and interact in a grocery store. All that together helps to really help us understand the individual and help make the best recommendations and guidance. So my background as an occupational therapist really helps me in this specialty area because of the importance of the IADLs. And, speaking about timing, one of the other statements is that if a person with IADL loss, that if you're having changes in IADLs, that's really a good signal that maybe we should talk about a driving evaluation to see if that's impacting that area as well. Now, this is different. I want to say, I talk to a lot of people whose family members have decided to start taking over paying the bills, right? Because it's a natural time to transition. So there's the difference between losing IADLs or not engaging in these activities because someone else is starting to help more versus unable to do it, right? And that's part of what we look at as well. I'm going to pause there for a second and take a sip of water, and you guys let me know if there's any questions with those couple things.
A few folks are asking what the range of charges looks like for an assessment, I guess with you or in general.
Yeah, so I can tell you, let me give you a range for myself as well as the other specialists in the area. I would say the evaluation typically ranges between $425 up until, I've seen it up to $550. For me, it ranges based on how far I'm traveling to get to you. And the other thing I will do to help people out is, for example, I have a client who is out in like the Ocean City, Wildwood area of New Jersey, and then another one who just called me in like the greater Atlantic City area. Both of those would be kind of far trips for me, but if I can coordinate it, we'll split the travel charge for the both of them. I try and do stuff like that as well to help people out.
And then the second question, you might want to, I'm assuming you're going to address this later, but there's a few questions about working with a family member who does not agree that it's time to be evaluated or stop driving. I'm guessing you're going to get to that, so maybe you want to save that for later.
I actually don't think I have a specific slide for that, so let's talk about it. That can be very tough, right? So people really value driving. I value driving. Driving isn't just about the things we have to do, right? I mean, it's helpful to be able to drive to get to the pharmacy and the grocery store and doctor's appointments and haircuts and so on and so forth. But driving is also about all those spontaneous fun things we do, going for coffee, meeting friends, right? And so when we talk about driving, there can be a natural resistance to evaluating it. What I try and share with the driver, with the family, is that my job is to really look at things as objectively as possible using those tests and measures. And then with the observation in the car, which I fully admit has some subjectivity to it, but we try and look at the behaviors overall. And I want people to know that my recommendation then is based on multiple different areas and multiple different things. So when I hit resistance, first the individual driver does have to agree to participate, right? And if it's being ordered by a doctor and the individual is refusing to participate, it depends on the doctor, but I will let them know. And some doctors will say, if you're not participating, then I feel like that's showing me poor insight and I have concern about your safety, and we're going to, report that to the state. I've had, other doctors handle it differently. So, and I'm not trying to be punitive, just more transparent, right? Because I don't like people to feel like their back is against the wall if they're not open to something. But as much as I can, what I have found is if I can share with somebody who has resistance, if I can share with them that I want to look at things objectively, that I want them to do everything that they can do, I want them to be as independent as possible. I know how important being able to move around the community is, and I really do value autonomy. So if I can kind of share those things and let them know that together, we're going to be looking at all this stuff and making a decision, I think that usually we can get people on board. Here's the other thing is, if let's say worst case scenario, we're talking about a situation where an individual is showing me a pattern of concern, is showing me a pattern of unsafe behaviors. It's still my information still comes back to the doctor so that together more than one person is making that determination and that outcome. Something important like driving, we need to have more than one discussion, more than one test done, so that's why we do multiple different tests to see how things look in that 3-hour period. And then, more than one professional weighing in. I'm always weighing in. So think about me. I kind of like explain it in this regard. I take an x-ray of the driving, right? So I might be the x-ray technician who's taking the x-ray, and I can see the broken bone. And I can say there's concern and keep your weight off of that, right? But I need to collaborate still with the doctor who's got the full medical knowledge of this individual's condition to say, yes, I agree. And then collaboratively we work together. And I know with Penn, you guys then support, as a whole team.
Yep. Um,
Did that answer that question? I feel like I did go a little around.
no, I think that was really helpful. We're getting, a lot of the questions are things like my parent either agreed to stop driving and now doesn't remember that they haven't stopped driving,
Oh,
and are asking to go out all the time, or when I approach my spouse or my parent or my partner and express my concern, they get very angry. So I think you definitely addressed that second one. Maybe a little bit more about the first one.
yeah, I have two thoughts on that. So the first thought is, um, if we're talking about a condition impacting memory, it's not fair for us to assume they're going to remember, right? And that's really hard because this person probably used to have a good memory, right? So my recommendation if is to in I have a strategy I use called the 3 R's of driving retirement. So these are removing access to the vehicle, replacing all the commute mobility needs, and then remembering the fun. So I'll go through those really quick. And I have a YouTube video that Allison, I could share that link as well, then that goes through more. But the idea that if we have somebody who doesn't remember that they shouldn't be driving, we need to remove their access to that vehicle. A lot of people think, oh, it's the driver's license, but quite honestly, people forget they don't have the license in their wallet and they go out and drive the car. The more important piece is removing their access. And so if it's your spouse, it means hiding the keys, right? And keeping the keys safe. If it's mom or dad and you're able to, you want to remove the vehicle. I always say the toughest thing about cognitive conditions is looking at an adult and realizing that the capacity is not the same level that they were at the very best of their life, right? And so in my head, I think about, let's say dementia, I think about almost people losing their layers. So if people layered up their skills, they're losing their layers. And so many times in my own experience, my own family members, they got to a stage where they were behaving similar to a 7 to 10-year-old, right? So if I have a 7 to 10-year-old and I'm saying, just capacity wise, don't eat the chocolate cake, I don't want to leave the chocolate cake on the counter, right? So the same thing about if that's their cognitive capacity, telling them just don't drive is not going to work. We've got to remove the car. We've got to remove the access. The second piece is, as much as you can, anticipate where they want to go, their habits and routines, and put something else in place. And put that thing in place. I like to say, put it in place so they don't have to ask. So if they always go to a poker game on Thursday nights, Dad, I'm ready to take you. Show up and be there. If they like to go to the grocery store on Wednesdays, honey, let's go. I'm ready to go. Oh, I'm going to drive this time. Jump in the car with me. Figure out what their habits and routines are and fill it in. And keep in mind, caregivers, you don't have to be the person who does all the driving all the time. You can have other people that you rely on or people who want to help. I think a great example is often churches. There can be people from church who always go to 8 o'clock mass. I had a gentleman a couple weeks ago. He goes to 7:30 mass every morning. He is now in the phase where he needs to retire from driving. So we reached out to the priest. The daughter reached out to the priest to find out who else goes at 7:30. Now he's got a buddy who's picking him up every day at 7:30. And he's getting there, if he normally left at 7:15, so this person's there at 7:10 every day to pick him up. So there's no question. You're coming with me. Let's go. Right. So replacing that as much as you can is helpful. And then, as I said, the last piece, the remembering the fun. Driving's about doing the fun things in life. And so, while you're planning a lot of replacement, remember to do some of those fun things as well. Is important. Allison,
Yeah.
my own working memory, I just forgot the second question.
I actually think you addressed it really well, Susie.
Okay. Are they both?
Yeah, one more question someone asked, which is a really good question. Do you ever suggest using something like a tile or an air tag in a car to track a driver who, let's say, is safe to be on the road, but you're concerned about their directionality?
Oh, okay. So navigation is, so there's two different things. If I have somebody, at baseline who is not good with directions, but they have a strategy in place, like they always use GPS, that is an acceptable thing to do and something I'll encourage. If changes in navigation, though, are something that's happening related to the cognitive condition, that is a big warning sign and flag and signals the need for a driving evaluation. So I think the question, like, I do have people track where a car is. They'll track, there's different apps you can use for, they developed these for teenagers, but they work great for everyone. You can basically make like a geo map. And so if somebody leaves a certain area, you know that they've gone outside their normal pattern and it'll alert you. When we have people who are, doing okay, and we're kind of monitoring their progress, I'll have people use different technology pieces like that. But if it's specifically that the person's already getting lost, that's to me is a red flag and a need for an intervention.
Thanks.
Any other ones with that?
Nope, I think you can move forward.
Okay, these are great questions. I really appreciate them, and we'll stop anytime. I've got a couple more slides though, because I thought this research was interesting. A couple more pieces. And we've kind of hit this piece already, but the national guidelines, I thought it was interesting that they said, there's no in-office test or battery of tests that have sufficient sensitivity or specific, boy, that's a hard word for me, specificity. They're not specific enough to be used as a sole determinant for driving ability. I love this one. You might think, oh, that kind of pokes holes in what you do, Susie, but it doesn't. To me, what this one says is we shouldn't use one test or measure to make a decision, which goes back to my whole thing with using multiple different tests along with observation in the car whenever we can to really understand where somebody is. What I do think is helpful is sometimes those in-office tests are a good flag and a good reason for us to dive deeper and to come to somebody like me so that we can look at the whole picture rather than make a snap judgment. Which goes back to the kind of this next bullet, that abnormalities on cognitive screens may indicate a driver at risk who needs that further assessment. So you might, interact with the neurologist or a physician assistant who does a cognitive test and says, okay, now based on this score, we think it's time for a driving evaluation. That's a very important thing and a very appropriate thing to do. They're not saying based on this score, you can't drive anymore. They're saying now you're falling in a range though, that it's time for us to look at this. And as a caregiver, you should heed what they're saying then, because it means that something is starting to change. It doesn't necessarily mean that driving retirement is happening at the appointment, but it means something's changing that we need to keep an eye on. What we don't want to happen, my job as a driving specialist is to help people transition from the driver's seat before there's a problem. But also I want people to drive as long as possible, right? So I've got these dual roles, but that's where the evaluation can really, really help us. I don't want someone to get lost. I don't want somebody to get hurt. I don't want somebody to accidentally back into something or someone, right? And what happens mainly when we're talking about cognitive changes is things slow down so much that we see problems with people making left-hand turns safely. We see problems with people knowing when to go at stop signs. We see problems navigating or figuring out how to find an exit in a parking lot. Like think about the grocery store. They've got those different cement islands and the entrance and the exit. And when we see that slowing down, those other problems signal to us and signal to me, okay, we got to look deeper here. We have to understand what's going on. Okay. When it comes to reassessment, so I just to keep referencing the gal I had earlier this week, so she is going to be somebody that we reassess. And the research says that persons with dementia who are deemed fit to continue to drive should be reevaluated every 6 to 12 months. And typically what I do is say 6 to 12 months as guided by the referring neurologist, especially with the pen memory group. These doctors are excellent. They're so good at their job. And so with them checking in every 6 months, they're going to know if it's time for that reassessment. And some conditions, so I'm not a physician. I don't have that medical level of training. So I need them to say, with this condition, it's got to be sooner, or with this condition, we can go a little longer. But they're going to help guide that. And that's where that partnership and collaboration is so important. It's great. And I know it might sound like I'm so kind of geeky on this stuff. We didn't have these guidelines even 10 years ago to help us. So we were all kind of going on gut and experience, but now we've got this research that really says, this is what we need to do, and we're on the right path with this, and this is why it's so important. And I love to be able to point to research anytime I can, because then it's not just Susie's opinion over here, right? It's valuable stuff that we can put out there. Allison, how are we doing with questions?
Great. I think we can move forward.
Okay. So just to kind of reinforce, my role, I do work for myself, right? I work for my own company, but I really see my role as collaborative with the driver, with the family, with, Allison and the other social group over there, with the physicians, like collaboration. Together, we can talk about this. But caregivers, so this was a really great guideline that came out that, again, like, let's empower the caregivers, but we now have research that says caregiver concerns with regards to driving should absolutely be taken seriously. And so part of my interview, and sometimes this happens with people when we're on the phone and we can talk privately, or sometimes this will happen through email. People will share concerns with me. But if you're a caregiver, your observations are very important. And what you say and think is important. Oh, this takes me back to the other part of that question is, as a caregiver, this is what I think when it comes to driving. It is not your job to police somebody. Please don't feel like I'm asking you to spy or, turn somebody in. That is not your job. I see your job as the person who gets to love them. Right? Love that person, take care of that person, lean on me as the expert to help guide those other decisions. Myself, the neurologist, the rest of the team, we're there to help guide those decisions. So when we're talking about something like driving, don't feel like you're doing something wrong by raising the question. You don't get to decide. I'll take it off your shoulders. Let me just take it. It's not your decision. It's not your choice. Okay. Your choice is to love this person and keep them safe. My job is to give the objective information where we can, to give my expert opinion, and then to work with the doctors who have the best knowledge of the condition. Okay. And when you love that person and we do the very best for them, the outcome's always going to be the best, even if it's a tough one. But I will say some general warning signs that I think are helpful to think about are getting lost. Getting lost is a big one. I will say, unless you're someone who always gets lost, I don't want to throw my sister under a bus, but she can't navigate herself down a straight road. She lives in Alaska now, so she's in good shape because there's 2 streets, right? But she's even got to turn her GPS on for that. That's different. That's her baseline. But I mean, like, now getting lost going to familiar places. I worked with a family who realized that mom was driving over to the adult child's house and it was taking longer than usual. And then they started to kind of watch, they turned on the Find My Phone app and realized that she was making wrong turns and going different places. That's a big concern, right? Because if you can't recognize a familiar path or make decisions with those familiar things and problem solve what to do, that's a big change. Listening to people if they start expressing anxiety or they start saying, oh my gosh, I feel like everyone's driving really fast. some of that, there's a little slowing down that happens as we age. I think we've all can admit to that. I'm starting to feel this a little bit myself as well. But the reality is, if everyone's passing you on the road, or you're having anxiety and feel like people are driving too fast, or they're coming out of nowhere, or just general anxiousness, that's of concern. Of course, confusion is concern. Stopping in the flow of traffic. If I've had family members express this to me, that's another really big concern, because that has to do with processing, thinking on the feet piece. And then we always ask about recent fender benders. I've kind of stopped asking about tickets, although tickets are a big one, but I found that a lot of police officers tend not to ticket our older adults. They'll just so sometimes I ask about being pulled over instead. Let's see what else we've got here. So, really, just to reinforce my role as a specialist is, again, I want people to be as independent as possible, right? Independence, autonomy. We know that getting up, going, moving, interacting is good for many, many things. And I'm balancing that piece with safety, so that not only the loved ones, not only the driver stays safe, but everybody else stays safe as well. And so that's where I see my role, is to helping understand, is a condition impacting safety? Is it changing the level of independence? And how can we support to maximize both? So those are my slides, but now I'm hoping maybe I've sparked a couple other questions, because we've got some more time.
So a few questions. This question says, my husband has not driven in 5 months, and in fact, we know he is not able to drive. What is the wife's responsibility at this point? Do I contact our insurance policy to remove him from the policy?
So I actually think that what I recommend doing is turn the license in for an ID card. And in many states, you can do that either through the mail, or by so I know Pennsylvania off the back of my hand, because I live here. In Pennsylvania, it's called a DL-54. It's an identification form. You fill out the form, you sign it. You can take that and the driver's license into the DMV, and they'll give you an ID card. Or you can mail it in and they send you back an ID card. And in fact, if you're doing it for medical reasons, which is one of the options, it's free. Okay, so I recommend doing that for a couple of reasons. One, it signals if the individual was somehow to get a hold of a car and go driving, right away, if they were to be pulled over or found, the police officer, whomever, would know right away, for medical reasons, they shouldn't be driving, and they'd be able to help. Okay. The next thing I would do is, I would remove them off of the insurance. They don't need to be on the insurance, and I would remove the vehicle unless you need it for your own personal use. But and a lot of those pieces can be done, by the caregiver without the involvement of the driver, the individual themselves. And then it sounds like you're able to support this person if it's been 5 months. So that's a really great thing too, but don't get burned out and lean on other people.
Okay. I think this is bordering perhaps on legal advice, but it is a general question, and a few people have asked it.
Okay, let's give it a shot.
All right. So the question essentially is, let's say that someone has an evaluation and they are told not to drive, or even they are stripped of their license by the DMV or by PennDOT, and then they end up driving anyway. What is someone's liability there as, let's say, a spouse, if that person who doesn't have a license is on the road and the spouse and family is aware of their diagnosis and it's documented?
That's a really tough one, because it comes down to kind of what's the outcome from that situation, right? So in that situation, let's say the person plows into a back of a school bus. Well, there's going to be a world of hurt and a lot of problems. And then it depends on, who's involved, right? And how deep it goes. if the person goes out and they get to the grocery store and they, are buying ice cream and they get home, well, then no one's really been hurt, but it's not good either, right? So I think it's very difficult to say the exact level of risk. I've seen a range of things. I've seen a range of things. In my role as an expert, I've been asked to legally I've been deposed for different situations. And the questions, it's not uncommon to say, was this a known problem? Who has been involved? You know, so the questions do occur. Yeah. I think it is on the one hand, what I'd love to say is I believe that if we're all doing our very best, that it's going to work out. But I don't think I can promise that.
Thanks, Susie. What if someone refuses to get evaluated?
So for me, if I get a referral and the individual doesn't agree to the evaluation, I can't complete it. I have not seen them drive. I can't pass judgment on it, but I would send that information back to the referring doctor. And then the referring doctor would have to make a decision from there based on the medical knowledge.
Yeah, I can only speak to what we do in our office, but if we've recommended an evaluation, it's probably because we have some concern for driving safety. And if someone is absolutely refusing to get evaluated, the doctor at that point might make the call to report that person's license to the state. But again, it's situationally dependent.
Yeah, and then reporting to the state can trigger a couple different things. I wish I could tell you how PennDOT operates 100%, but there's an algorithm that I don't quite fully understand, even practicing here for 12, 15 years. But sometimes it triggers an automatic suspension. Sometimes it triggers a suspension and medical forms to be completed. So it can trigger different things. I think my personal experience is the PennDOT process can be difficult to navigate in the different components. And you just have to remember that's one piece of it here, right? So if we have an individual who's likely facing something, we have a concern, I would say that's time for as a group to get together and talk about how can we support this individual the best? What is best for this person? And remember, it's not on you as the caregiver to just do it by yourself, right? Yes, you probably live with this person and you might have the brunt from day to day, but there's resources and we can help the best we can too.
Yes, I want to emphasize that also. If you are a Penn Memory Center patient and you haven't worked with a social worker before, please reach out to us. We can help support you in setting that boundary. I sort of answered this one in the chat, Susie, but I'm interested in your take. When you're giving an evaluation, would you recommend kind of in between options like daytime driving only, or stick to local streets and no, freeway driving?
So for me, I used to do a lot more of that. However, here's where I sit right now. I like to understand what somebody's current habits and routines are. And most of us tend to kind of curb our habit and routines anyway. So if I find out, someone typically doesn't drive at night, or and it'll be interesting because people say, oh yeah, I drive at night. And then I say, well, where do you go? I don't go anywhere at night. Right. Right. And the family can tell me, yeah, they go 3 places: the grocery store, the hairdresser, and over to her friend's house. Right. I'm not going to change somebody's habits and routines. The other thing I'm always very aware of is it would be unethical and inappropriate for me to recommend a change in behavior if somebody has a memory impairment. Okay, so that's kind of interesting, right? Memory impairments by themselves do not mean that you can't drive. Memory impairments, changes in attention, changes in executive function, changes in processing speed, any combination of those is when we start to get concerned, right? So you can have problems with your recall and manage that. But so I typically don't recommend anything if it's different from what they're already doing. And if there's a reason why, then we're really going to dive in to think about, should this person still be driving or not? Is it appropriate? Can we rely on them to make this change? In Pennsylvania, they do have nighttime restrictions and other restrictions like that, but that would, the other piece of that is if we're going to apply that and enforce that, we really need to report it.